Hello, and welcome to today's webinar, Telemedicine for Nursing Homes. Before we get started, I'd like to introduce a few housekeeping notes. Today's session will be recorded and will be available to view in a few days after the webinar. You will receive an email with a link to the recorded version. You're welcome to share this video with colleagues. We will have a question and answer period at the end of this webinar, but you're also welcome to ask questions at any time. Bobby would love for this to be interactive and will jump in and answer questions as they come in. You can type questions in the chat box at the lower right section of your screen. For some of you who are new to telemedicine, RelyMD was started by a group of emergency medicine physicians looking to provide virtual care throughout North Carolina. One of the clear areas that needed improvement were care transitions. The best recognized areas include those periods of time at a skilled nursing facility, post-acute care rehab, and post-discharge back to their home. RelyMD is committed to recognizing these areas of improvement and are constantly looking for partners in the post-acute and long-term care community. Now I'd like to introduce our webinar presenter, Dr. Bobby Park. Dr. Park is co-founder and director of virtual health at RelyMD. Dr. Park graduated from Columbia University with a Bachelor of Arts degree in economics. He received his medical doctorate from the University of North Carolina at Chapel Hill in 1998. And he completed his medical residency and fellowship at Alameda County Medical Center Highland Hospital in Oakland, California. He is board certified in emergency medicine and has been practicing since 2003 at WakeMed Health and Hospitals. Bobby, I'll turn it over to you.
Thank you so much, Chelsea. And I'd like to thank all the attendees. Thank you for taking time out of your busy schedules today and joining us. I'll be walking you through today's presentation, which is outlined here. I just want to take a brief moment to tell you all why we as a private group of ER physicians, and I'm fortunate to be a part of a progressive group of 105 doctors in our private practice ER physician group, why we decided to get into the business of telemedicine, and especially for nursing homes. Well, we work clinically in the emergency department every day, and every single shift, we take care of elderly nursing home patients. Some of these patients for sure needed to be evaluated and treated because they were sick, but I would say a lot of them were also, I'd walk into the room and I'd say, "Hi, Mrs. Smith, what's wrong?" "Well, I feel fine, Dr. Park. I don't know why I'm here." So then, I would do my best impression of Sherlock Holmes and get on the phone, call the facility, and speak to the nurse who sent the patient that day. And then, not infrequently, I'll get the answer, "Oh, shift change happened, and that nurse went home." But I think maybe they sent Mrs. Smith because she was confused. So there's this inherent communication breakdown and difficulty whenever you move a patient from one facility to another. And I think those care transitions are documented as being a very vulnerable time for care to potentially drop. So in any case, we have said for many years that we could evaluate these, if only we could evaluate these folks before they actually came to the emergency room, then we might be able to save them a trip. Well, now with technology, we can actually do that. Rather than the patient coming to the ER, which we all know is, again, not ideal oftentimes for the frail elderly for lots of reasons, fear, confusion. Oftentimes they end up getting in a busy ER, they get lack of medical attention. Sometimes, unfortunately, they get too much attention. They get over-testing. And then finally, sometimes they in being such a unfamiliar, busy place, they'll have changes in mental status and sundown and all sorts of bad things like that. So in any case, the ideal would be to have them in their own home environment and then let the emergency physician come to them via technology. So let's get right into it. Overall, the agenda we're going to go over today, we're going to go over a brief review over what telemedicine really is and how it affects nursing homes. We're going to talk about trying to reduce readmissions to the hospital in the post-acute care setting, the cost savings involved, how telemedicine might attract new patients, and then just basically how it works from start to finish. And at the end, we'll save time for questions and of course, announce the winner of the gift card. So when we talk about telemedicine, a lot of folks have different ideas about what telemedicine is. For some folks, they think about direct-to-consumer online urgent care, where you think about folks who have sinusitis and they use telemedicine, they get to see a doctor direct to consumer, and they end up getting a prescription called into their pharmacy. Some folks think about telemedicine as being, for example, tele-ICU, where one physician is able to monitor hundreds of different ICU beds remotely. For telepsychiatry, psychiatrists are able to evaluate patients remotely to discuss their problems and render psychiatric care. For teledermatology, it's taking all kinds of pictures, very detailed ones of their rash, and having the physician interact with the patient, making a diagnosis and instituting treatment quickly. And some folks, it's telestroke, which is probably one of the best recognized forms of telemedicine, where a neurologist is located remotely somewhere, and then usually at some large academic center, and there's a nurse with a patient out in rural emergency room somewhere, and they're trying to get evaluated for possible TPA. So telemedicine is, the way I like to think about it, is just a technology that physicians and nurses and medical folks can use to solve a problem. So why is there even a need for this? Well, in my mind, it's a couple of things. On the regulatory side, CMS, just earlier this year in July, started tracking 2 new quality measures that affect your nursing home Compare 5-star rating. And that is percentage of short-stay residents who were rehospitalized within 30 days, and also the percentage of short-stay residents who had an outpatient emergency department visit. And they cite that in both of these cases, these metrics reflect sort of the diligence and the level of care provided at that nursing home, so that they can then use that in their 5-star rating. So let's just note that this is actually being tracked at present, and it sort of paints a picture of the heated regulatory climate that you all have to deal with every day. So then now let's also look at how facilities are set up. So I believe most nursing home facilities, they don't have a physician or physician extender on site 24/7. There is typically someone on call, but therefore by default, when there's an urgent or an emergent medical question or issue that pops up that a nurse or a nurse's aide feels needs answering, they will contact that on-call medical provider, and it's usually by phone. Now, we all know, even with the absolute best nurses providing relaying the best information and care, the medical care rendered is limited by phone, because the bottom line is the provider on the other end can't see or examine the patient. They can't. I guess they could pass the phone off to the patient and actually talk to them, but that's a very rare circumstance, and that just doesn't happen. So that provider can't look at the patient and get a sense of how serious the situation is, and oftentimes they're going to, take a conservative approach, which isn't necessarily bad given the circumstances that they're being relayed the information. But a good example is, you hear about an elderly patient with diabetes who's been nauseated and vomiting and has a blood glucose of 580. I mean, that all sounds terrible. But then when you see that, the patient is smiling and they're joking and they're their usual mental self and they're still alert, suddenly things change. There is time, and there is probably an alternate management strategy where you can actually give that patient insulin and medication there at the facility and giving them a chance to improve before shipping them to the emergency department. So in any case, there are limitations with the current system, as we've outlined here. Finally, families can be a major contributor to unnecessary ED transports as well. The patient is post-discharge from the hospital, where, in the hospital there's diligent care where every single day there's rounds of the medical team. Now they're in the skilled nursing facility, and mom hasn't been seen by the doctor for 24 or 36 hours, and family thinks that something's wrong, and they want mom back in the hospital because this is just not right and she needs to get checked out. Well, with telemedicine now, with convenient access now, you can have board-certified emergency physicians 24/7 when your physician is not on site or the physician extender is not on site, these physicians, through technology, can fill in these gaps and be a resource to your nurses, your patients, and also their families. The idea here is to provide good care that is better for patients because they don't have to go to the ER. And then telemedicine and the physicians, they're a resource to the nurses to meet their needs. And finally, family feel reassured and hopefully their expectations are met as well, all leading to decreased hospitalization and ED transports. So potentially avoidable hospitalizations among nursing home residents are costly to the facility and expose residents to additional health risks. By utilizing telemedicine, skilled nursing facilities can prevent these hospitalizations by treating the patient within the facility with the help of our board-certified emergency physicians 24/7. Some data. In 2015, according to CMS, 45% of hospital readmissions among individuals receiving either Medicare skilled nursing or Medicaid nursing facility services could have been avoided. In 2015, according to CMS, this equated to 314,000 potentially avoidable hospitalizations, resulting in $2.6 billion in Medicare costs. If you do the math, each avoided hospitalization saves Medicare $8,280. Many hospital transfers are initiated because of a lack of available after-hours providers. When a bed sits empty due to hospitalization, thousands of reimbursement dollars can be lost. So according to a report by the Kaiser Family Foundation, studies indicated that 30 to 67% of hospitalizations among facility residents could be prevented with well-targeted interventions. This is a graph that came from a study from Health Affairs in 2014. This study enrolled 11 nursing homes in Massachusetts. 6 of these nursing homes implemented telemedicine, and 5 of these nursing homes did nothing different. Standard care as usual. They matched them so that the 2 groups had the same hospital readmit rates at baseline, same 5-star compare rating, same distribution of post-acute care versus long-term care patients. Now, of the 6 nursing homes that used telemedicine, turns out 4 of them actually used it appropriately, and they called those folks the more engaged facilities. And then 2 of them really didn't use it very much. And they talked about why this low adoption occurred in those 2 facilities, but bottom line, just as you could imagine, there are some facilities that are more open to new ideas and some that are less likely to try something new. It turns out at the end of the day, the facilities that were more engaged in utilizing the technology saw an 11.3% decrease in hospitalizations. They calculated that there was a savings of $151,000 per nursing home per year. And after factoring, per year, that's exactly right, that's annual. So, and I feel this is very important. In 2018, CMS has already outlined that nursing facilities are going to be subject to financial penalties, not just, these quality metrics that we're talking about, which do affect your 5-star compare rating. That's one thing. But now they're actually talking about, in 2018, instituting financial penalties for these same quality measures. And in digging a little deeper about some of the details of this, it turns out in North Carolina, there is mention of withholding 2% of every nursing home's reimbursements. And that 2% is held, and then the quality measures are tracked and compared amongst peers in your state. And then depending on how you stack up to your peers, you're going to be eligible to get back 1.5 to 1.75% of those withholdings. Again, all subject, and they made this very clear, CMS made this clear, this is all subject to change but right now that is the current plan by CMS. So using telemedicine can be an attractor to your facility. So let's talk very briefly. Hopefully telemedicine can improve your nursing facility financially in two ways. One, the cost savings we just talked about. By having less ED transports and less readmits, you're going to have more patients in beds at midnight and prevent loss of beds over 48 hours. In 2018, we talked about the direct cost savings just as we discussed. But also, financially, you would hope a second way would be on the marketing side, that now telemedicine and having 24/7 access to board-certified physicians who actually evaluate your family member in your facility, that's providing innovative, high-quality care that others don't have, and hopefully would be a differentiator in your local market. Also, by hopefully affecting those readmits and ED transports, your 5-star compare rating will improve over time, and that alone will also hopefully attract new clients. So, how does this work? This is a workflow explaining sort of step by step. So, let's say there's a medical issue that a nurse or nurse's aide is concerned about. They feel like this situation is perfect or is an appropriate use for RelyMD. These can be written out in a protocol sort of format so that the nurse has a very scripted sort of, straightforward protocol to follow. And this basically means the nurse brings an iPad or a computer, usually it's on a stand or a cart, to the bedside of the patient who's having that issue. The nurse clicks on the app, puts in user ID and password for the nurse, just like they're logging into an email account. Then it asks her the name of the patient and why they are asking for the consult. Then a RelyMD doctor immediately receives a text message and hops on the computer. The doctor may get on the electronic medical record to see the patient's medical history and their MAR. And then when they're comfortable, they hit begin consult. And right now, there's a less than 10-minute wait time. So once they connect, the nurse tells the story about what's going on with the patient. The doctor asks the nurse questions. They get vital signs. And then doctor will ask to talk to the patient and then have a facilitated exam where the nurse is the doctor's sort of ears and hands and be able to examine that patient in real time while looking at them through the screen. Then, based on that evaluation, the doctor and the nurse, they make a plan together. And a good example is the patient with an unwitnessed fall. It may be rather than sort of knee-jerk and understandably, there's patients who you're concerned about may have an occult fracture, or there's a lot of medical legal liability around unwitnessed falls, especially in nursing homes, that the knee-jerk reaction is to send them to the emergency department for an evaluation. Well, this way, the physician can evaluate the patient in the facility. They're walking at their baseline function. Their mental status is not changed. They're not on anticoagulation. Well, you know what? Let's go ahead and just be conservative. We can keep them here in the facility. We can do 2-hour neuro checks and just make sure that the patient hasn't had a change through the course of the night. And then when the doctor or physician extender gets there in the morning, the chart and the encounter will be summarized in their inbox. That would be the electronic medical record that we e-fax to them. And then they pick up from there and can follow the patient as well, order any studies or x-rays that may or may not be indicated. But basically the baton is passed to the regular medical providers in the morning to finish out that plan. Now, if it turns out that we'll be the first to say if it's a emergency, we'll be the first to say that is an emergency department visit that needs to happen, and we will also help facilitate that visit will call the emergency department that they're going to and explain why they're headed that way. That is probably the nicest, fastest, or most appreciated phone call that ER doctor is going to get that night, because again, half the time you don't know why a patient has landed in their emergency room, and to have another medical professional who's evaluated the patient and telling them why that patient's coming and can do a focused examination and workup, that's really great for both the physician on that end as well as for the patient, so that if it is just a visit, and perhaps they can get back to the facility in a faster manner. So to reiterate, with RelyMD doing telemedicine, and again, telemedicine companies are different. Each one has their own sort of technology. Each one has their own sort of protocols. Well, for us, RelyMD, the physicians are available by mobile app or by computer. We make it a priority to be available 24 hours a day, 7 days a week, 365 a year. And we staff RelyMD just like it's one of our other emergency departments. It's not a physician that you're going to get who's busy working at one of our ER facilities. It's a physician who's dedicated just to telemedicine and to handle these calls. In fact, we have a backup system where if we get multiple phone calls, we have a system in place where physicians are notified that there's a logjam of calls in the waiting room, and we decompress them by notifying other physicians. Right now, our wait times are less than 10 minutes, and in fact, they're closer to 7 minutes. And this is the conclusion slide. I think we hit everything we set out to cover. In summary, telemedicine is a growing area of medicine, and it's not going away. It is, nowadays, it's all about cost savings and efficiency. Telemedicine addresses both of these and can be done in a high-quality manner if you have the right doctors on the other end of the line. The number one goal is to provide the best medical care. And by doing so, it will reduce readmissions, reduce outpatient ED transports, and improve both nurse and family satisfaction. Not only will it save money, but you can market that you have 24/7 board-certified emergency medicine coverage through RelyMD, providing the absolute state-of-the-art technology and medical care in your facilities, hopefully a market differentiator. Now, if you'd like to experience RelyMD firsthand, please visit this website and request a demonstration. We'll be happy to walk you through how our doctors help facilitate a visit with you and your staff members. And with that, I will take any questions that you all might have.
Perfect. Thanks, Bobby. So we do have a few questions. I can read those to you here. So the first one is, how is pricing structured and who pays? Is that the individual resident or the facility?
That is a great question. So it is the facility. And right now, I'm just going to be very upfront and open. CMS does not reimburse for this service. Right now, there's a lot of discussion and legislation about reimbursement of telemedicine by CMS. CMS does reimburse certain types of telemedicine encounters, but right now, these nursing home encounters are not reimbursed. So right now, the individual nursing home has to see the value in it, has to see that this is the future of it, and are willing to subsidize the service on behalf of their patients. So currently, those are what our customers are doing right now.
Great. Next question is, would this take the place of a current medical director?
Another great question. So absolutely not. It does not take the place of a medical director. The medical director is an invaluable, just like the nurses there, the medical director is part of the infrastructure and is just probably one of the most important pieces to the medical care provided to those families and patients. We are an adjunct, and if you want to think of us as another club in the golf bag for the nurses, we're a resource for them to use when perhaps a physician or the medical director or their physician extenders are not on site. because let's just face it, if there's a patient who has a medical issue and the physician happens to be there on site, then that's perfect. I mean, there's not anyone who's going to know that patient better than them. They admitted them, they've been following them, they've been making recommendations, and so when an issue comes up, they're the best qualified to know whether that's a new thing or an urgent issue, or if that's just something that is baseline for the patient. So we are an adjunct, and we are especially useful in those settings where the physician or physician extender is not on site.
Great, thank you. Another question we have is, how long does it typically take to get up and running within a facility?
Yeah, fortunately, we've kind of gotten our feet underneath us now, and we've onboarded several clients, and we've been doing this now for about almost 2 years. This coming January 2017 will be 2 years. So we can be up and running typically within 1 to 2 months, depending on the needs and depending on the infrastructure of the nursing home.
Okay, and last question, what types of conditions can be treated?
That's a great question. So for the most part, as you can imagine, there's the usual protocol for the nurses is to contact the on-call physician or medical provider who's on. And so as you can imagine, if there's a 911 emergency where let's take, for example, just extreme respiratory distress or cardiac arrest, well, that's not going to change. If you contact RelyMD, we're going to say, hey, that person needs to go straight to the ER. So 911 lights and sirens conditions are handled exactly the same. Likewise, the minor quick questions, for example, med clarifications or clarifications about admission orders, those would still typically go to the medical provider. The on-call medical provider. But anything that requires an evaluation and possible treatment, that's a perfect, anything in between, what I would call urgent conditions, would be a perfect call for RelyMD. So, for example, high blood glucose, altered mental status, fall, unwitnessed fall, headache, uncontrolled pain, fever, anything like that, anything basically that requires, again, a medical evaluation and a treatment plan would be an ideal candidate for RelyMD.
Perfect. So that was the last question that we have time for. So thanks so much for submitting those great questions. And we are ready to announce the winner of the $50 gift card. The winner is Amy Griffin. Amy, we will email you directly after this webinar with your $50 Starbucks e-gift card. And thanks again to all who were able to attend the webinar, and thanks to Dr. Park for his wonderful presentation. Again, we will be sending out a recording of this webinar, so if you missed anything, look out for the video, and you'll be able to review all of those topics right from your computer. And if you're interested in learning more about RelyMD and how it can work with your facility, please feel free to reach out to Dr. Park, and we will send his contact information out after this webinar. Enjoy the rest of your day.